Surveillance and Diagnosis of Hepatocellular Carcinoma. Jorge Marero, MD, MS. I have nothing to disclose in this presentation. The development of hepatocellular carcinoma requires a malignant transformation. It starts in a normal liver that is infected with hepatitis C, hepatitis B, alcohol, or fatty liver. Over time, the inflammation and fibrosis that happens with these chronic liver diseases leads to the development of cirrhosis. Once cirrhosis develops, if the liver disease continues, then the patient is at risk for developing dysplasia and then cancer development. The molecular pathways that lead to this transformation from cirrhosis to dysplasia to cancer is an active area of research and being better understood as we speak right now. Therefore, one of the important aspects of hepatocellular carcinoma is that it occurs in the presence of liver disease. So we have an at-risk population that we can target to either prevent it or to diagnose it early. One of the most important aspects on surveillance and diagnosis of hepatocellular carcinoma is to determine when you have a patient in front of you whether they have cirrhosis or not. There's a progression, for example, in hepatitis C, that you start with no fibrosis until you develop cirrhosis based on the amount of fibrosis on a biopsy. When we have a patient with abnormal liver tests or they have a chronic liver disease, one of the most important aspects that we deal with, that we have to do, is stage the patient when we see them. Do they have no fibrosis or do they have cirrhosis? And that can be done by evaluation of the blood test, but the gold standard is liver biopsy, and that's one of the most important things that we have to do to identify whether patients are cirrhotic or not. The reason that we want to know if someone is cirrhotic is because their incidence of hepatocellular carcinoma is high. If you look at patients with hepatitis B, patients with cirrhosis are at a higher risk of developing liver cancer per year compared to those that do not have cirrhosis, as shown in this table. Patients with hepatitis C also, if you have cirrhosis, you are at a higher risk of developing hepatocellular carcinoma compared to those that do not have cirrhosis. And also the same applies to alcohol. Therefore, identifying patients with cirrhosis is important because they are at risk for developing hepatocellular carcinoma. A recent guideline showed that the patients at risk of developing hepatocellular carcinoma are patients with hepatitis C-related cirrhosis, primary biliary cirrhosis, genetic hemochromatosis and cirrhosis, and alpha-1 antitrypsin deficiency with cirrhosis. Among those with hepatitis B, those at risk were those that had hepatitis B-related cirrhosis, Asian males over the age of 40 with chronic hepatitis B, Asian females over the age of 50 that had chronic hepatitis B, patients with hepatitis B that have family members with history of liver cancer, and patients that live in Africa and sub-Saharan Africa that also have chronic hepatitis B. Those are the ones that are high risk, and those are the ones in which surveillance is recommended. Surveillance for hepatocellular carcinoma is the repeated testing of alpha-fetoprotein and ultrasound every 6 months. The main data to show that surveillance does really improve outcomes is a large randomized trial performed in China. These were close to 19,000 patients that were randomized to ultrasound and AFP every 6 months versus patients with hepatitis B that did not undergo AFP on ultrasound. In terms of the occurrence of HCC, it was higher in the screening group versus the control group, but barely reached significance. But the most important part of this study is that the death of HCCs was dramatically reduced, 37%, compared to the no surveillance group. This study shows that the strategy of surveillance with AFP and ultrasound every 6 months reduces mortality 37%. So what about a Western population, either Europe or North America, in which the most important cause of hepatocellular carcinoma is hepatitis C? There are no randomized trials in a Western population with chronic hepatitis C-related cirrhosis. There are several studies that have evaluated ultrasound for the early detection of HCC, and a recent study evaluated all of them in a meta-analysis. And it showed that ultrasound for the diagnosis of early-stage HCC had a sensitivity of 63%. One of the important things of this study is that AFP improved the sensitivity to 70%. And also this study showed that doing AFP and ultrasound every 6 months was better than every 12 months. In terms of the cost-effectiveness of AFP and ultrasound, there are several cost-effective analyses that have been performed. One study showed that the strategy of surveillance with AFP and ultrasound had a cost-effectiveness ratio between 26,000 and 55,000 quality-adjusted life years. So therefore, it is cost-effective. However, we're doing quite poorly overall in surveillance for hepatocellular carcinoma. A recent population-based study evaluated close to 2,000 patients with HCC throughout the United States. It showed that only 17% underwent regular surveillance, 38% underwent inconsistent surveillance, and more importantly, 44% did not undergo surveillance at all. GI hepatologists and those affiliated with an academic institution had a higher yield of surveillance, but overall, across the board, it was all quite poorly done. So therefore, we need to identify patients that are at risk for developing hepatocellular carcinoma and apply this ultrasound and alpha-fetoprotein, which are both cheap and easily obtained. In terms of diagnosis for hepatocellular carcinoma, one of the first aspects is an evaluation. We have to do a physical exam, determine if the patient has a history of liver disease, and determine if they have stigmata of chronic liver disease or portal hypertension. Another important aspect that we have to remember in hepatocellular carcinoma is that the liver has a dual blood supply. Most of the blood supply comes from the portal vein, about 80%, and about 20% comes from the hepatic artery. As the nodule changes from dysplasia to cancer, the process of angiogenesis leads to the development of an arterial blood supply that feeds the tumor. So therefore, when we perform a diagnostic study to determine if the patient has hepatocellular carcinoma, it is very important to account for the dual blood supply of the artery and of the portal vein. If these studies are not done in a triple phase manner, meaning no contrast phase, the arterial phase, and the portal venous phase, we can miss tumors. This slide shows an example of a triple phase imaging of hepatocellular carcinoma. We first have an imaging without contrast, then an imaging with the arterial phase that shows the arrow of an arterially enhancing lesion in the right posterior lobe of the liver, and the last phase is a portal venous phase in which the tumor disappears. So it is quite important to do it in a triple phase manner. Unfortunately, most of the scans, either MRIs or CT scans that are done for diagnostic purposes, are not done in a triple phase manner and only done in the portal venous phase. So it's imperative if you have a patient with cirrhosis in which you have a suspicion that the patient may have cancer, or they have an abnormal surveillance test, like an elevated AFP or an abnormal ultrasound, that a triple phase examination be given. Another important aspect on the diagnosis of HCC using CT or MRI is the concept of washout. We did a study to show the importance of doing a triple phase study. So what we show was if there's a lesion in the liver that enhances in the arterial phase, but that there is hypointensity in the portal venous phase, that is called washout. And washout of contrast, if it's present, increases the risk of hepatocellular carcinoma 60-fold. The next slide shows an example of what contrast washout is. In the left, you will see an arterial phase examination of the liver in which there are two arterially enhanced lesions on the arterial phase, as shown by the arrows. However, on the portal venous phase, you have two lesions that are hypointense, consistent with washout. This has a sensitivity and specificity over 90% of being hepatocellular carcinoma. So if this pattern is seen on CT or MRI in a cirrhotic liver, the patient has hepatocellular carcinoma. MRI and CT has been compared in the diagnosis of HCC in cirrhotics, with the gold standard being explant. This table shows the number of patients, the number of nodules, the number of patients with HCC, and the sensitivity and specificity of both CT and MRI. As it's shown here, MRI is more sensitive for detecting hepatocellular carcinoma compared to CT scan. So therefore, MRI is the modality of choice. However, not everyone with HCC will have washout. There are some cases that will be atypical. It has been estimated that about 85% will indeed have washout. But as you see here in this table, there are some patients that do not have arterial enhancement or hypointense HCC, or that the lesion enhances but does not wash out and also have HCC. So if there's a cirrhotic patient that do not meet the characteristics of washout, but they have a lesion in the liver, a biopsy must be performed. There is a new modality on MRI, a new contrast agent called EOVEST. The advantage of EOVEST is that it is excreted both by the liver and the kidney. As I show in this slide, the advantage of EOVEST is that it can perform an arterial phase, a portovenous phase, but also a hepatobiliary phase. So in hard to characterize lesions, as shown here that there's an arterially enhancing lesion that did not wash out, on the hepatobiliary phase, it appears hypointense. And therefore, it shows that those lesions do not have functioning hepatocytes and therefore are highly suggestive of hepatocellular carcinoma. So MRI with EOVEST may add to the diagnosis of HCC. The ASLD has developed criteria for the diagnosis of HCC. What is most important from this slide is that if you have an arterially enhancing lesion that also washes out, you have a diagnosis of hepatocellular carcinoma confirmed and no biopsy is needed. If the patient does not exhibit washout, then a biopsy is needed to confirm the presence of hepatocellular carcinoma. So to conclude, patients with cirrhosis, especially hepatitis C in the United States and the VA system, are at risk for developing hepatocellular carcinoma. Ultrasound and AFP are the most important surveillance tests, and they should be performed every 6 months. This strategy has been proven to decrease mortality. And a typical pattern on a CT or MRI of washout is the best method for diagnosing HCC.